And good afternoon, everyone. Welcome from Jefferson City, Missouri, in the central office of the Missouri Department of Mental Health. My name's Tom Pansella. I'm with the Missouri Institute of Mental Health. Thanks for taking the time to watch this web conference called Understanding and Responding to Suicide in Our Communities. I'll introduce our presenter, Dr. Ronda Oswalt Reitz, in just a moment. If you're interested in asking a question, submitting any feedback, you'll see a chat window right underneath the video window. All you got to do is type your comment next to the word "say" and hit that "say." You don't have to log in. If you get a login, you've hit the wrong button. Click that "say." The first time you do that, you'll probably have to enter a nickname for yourself, but after that, you should be able to just join us in the chat. If you're interested in purchasing CEUs for today's program, it's $10 a person. Down at the bottom, there is a link directly to the CEU application form. You'll see also a link to Rhonda's slides, so you'll be able to open those in a separate window as a PDF if you want to follow along that way using the slides. So I'd like to introduce Dr. Ronda Oswalt Reitz, and she earned her PhD from the University of Kansas in psychology, and she currently works for the Missouri Department of Mental Health, developing DBT programming. She provides consultation and supervision to staff in both public and private mental health settings in the United States. And she was the previous DBT Program Coordinator for Fulton State Hospital, which isn't very far from here. Rhonda, thanks for being with us, and the show is yours.
Hi, thanks, Tom. Good afternoon. Today we're going to be talking about how to appropriately assess and general responses to suicidal behavior. And within the rubric of suicidal behavior, what I'm talking about, of course, is actual attempts, ideation, or self-harm behaviors that may lead to suicide behavior. So the first thing I want to talk about is our own response to suicide. And while we're not going to do this exercise, there is an exercise in this first slide that you can do with your own clinical teams back in your own setting. And the idea of this is to expose ourselves to the thoughts, the feelings, and the associations with suicide that we typically don't spend time thinking about or focusing on. And the reason for doing that is because it's really critical if we're going to do a thorough and effective assessment and develop a good plan of intervention for us to have a minimum of emotional response when we're in the face of suicide behavior. Typically, we don't get that kind of exposure to suicide materials, and so it's pretty important to spend some time as a team, maybe watching some videos that are related to suicide, talking about your thoughts and feelings and beliefs about suicide, and thinking about times when you have been confronted with a client, a loved one, or an acquaintance who has engaged in suicidal ideation, threats, or behaviors, so that you can keep your response relatively low internally. No one has a completely low response to suicide, but it's one of those things that unless you can keep your wits about you, you're very likely to make mistakes in the assessment. So for individuals who are suicidal, the solution to all of their problems is suicide. Of course, for us, we're on the entirely different side of the issue, and for us, suicide is the problem that we're treating. So understanding that we're coming into the assessment of suicide from such opposite positions is pretty important in beginning this assessment. Often individuals who are confronting thoughts of suicide have unbearable amounts of pain that they're experiencing, and the thought of dying is not appealing in and of itself. It's the thought of escaping those unbearable levels of pain. So who are the people that are considering suicide? You can see some statistics. I'm not going to go through all of the slides that have statistics on them, but suicide is a leading cause of death. Worldwide, it is 9th, 11th in the United States. You can see that broken down by age. It is the 8th cause of death for men and 17th for women. The 4th worldwide for people in the late adolescent and early to mid-adulthood. In the United States, you can see that suicide is a very significant health issue for us. About 13.5% of people think about suicide in any given year, and almost 2% more people die of suicide than homicide. Certain mental disorders and emotional disorders put people at increased or different levels of risk. Certainly, you will see risk associated with schizophrenia, depression and bipolar disorder, addiction disorders. Borderline personality disorder is the single highest diagnosis associated with suicide. Approximately 10% of individuals who are diagnosed with borderline personality disorder will die of suicide, ultimately. Very often, suicide attempts are associated with drug or alcohol use or abuse, and these are the dispositions of individuals who presented at an ER following a suicide attempt. So you can see that many are admitted to ICU or critical care. Many were transferred to another health facility, so those are pretty significant medically involved suicide attempts. And then 31.2% go to psychiatric ward is probably the greatest number of the 31.2% that are accounted for by being admitted to that hospital. In 2004, when researchers looked at people who had committed suicide or made suicide attempts, they found that 41% of those individuals had a psychiatric condition diagnosed, and those were drug-related suicide attempts. The most common one was, of course, depression. Another study showed that among individuals 18 or older who experienced in the past year a major depressive episode, about 56% of those individuals thought during their worst or most recent episode of depression that it would be better if they were dead. 40.3% thought about committing suicide. 14.5% made a plan, and 10.4% made a suicide attempt. So major depressive disorder is certainly highly associated with suicide behaviors. Among the number of suicides completed, 40 to 65% of those individuals have some sort of personality disorder. And among personality disorders, of course, borderline personality disorder is the highest diagnosed. Individuals who are diagnosed with 3 or more conditions, mental conditions, have a much higher risk of committing suicide ultimately than individuals with fewer diagnosed conditions. And there are a couple of slides with graphs on them now that show the diagnoses of individuals who are suicidal and diagnosed with borderline personality disorder. We know that that diagnosis is often associated with multiple diagnoses. And so if you take a look at this particular slide, you have both lifetime and current at the time of suicide event diagnosis for these particular disorders. The one that you don't see on here is bipolar disorder, and that is because this was a study that included individuals that were under treatment or would be under treatment with Marsha Linehan. And because the most effective treatment that we have for bipolar disorder is medication, these particular individuals were off medication during the time of the study, and so we were unable to include bipolar individuals in that study. It wouldn't have been ethical. Within suicidal borderline personality disorder, if you take a look at the range of Axis 2 diagnoses, you see that the highest associated diagnosis is avoidant personality disorder, and then antisocial, and so on from there, with obsessive compulsive also pretty highly represented among that group. There are a variety of suicide factors associated with different diagnoses, and I have just a couple of examples here. For schizophrenia, if someone has a pretty high level of functioning prior to the onset of their schizophrenia, this is associated with a higher risk of suicide, and presumably because of the grief and loss issues associated with that. Immediately after diagnosis, people are at higher risk. Early in the course of their disorder in general. During hospitalization, people are at greater risk. And shortly after discharge from inpatient, which is consistent across diagnostic groups. When people suffer from depression and hopelessness and they are schizophrenic, they have much higher risk. This is true for other diagnostic groups as well. And when they have lower negative symptoms, so that would be, for instance, the blunted or flat affect that people show when they have a diagnosis of schizophrenia. Those symptoms, as opposed to the positive symptoms of hallucinations and those sorts of things, are more associated with suicide. Only 8% of suicides are in response to command hallucinations, and this flies in the face of common lore about schizophrenia and suicide. Most people assume that that's a much higher rate than it is. Of course, alcohol and substance use disorders come with very high risk of suicide. They're highly associated. And if someone is in an acute intoxication, whether from alcohol or other substances, this is a high risk. Comorbid borderline personality disorder, of course, and comorbid major depression, depression, hopelessness, and impulsive aggression are also risk factors. Affective disorders, so that would be depression, bipolar disorder. History of suicide attempt is probably our best predictor of future suicide attempt, but history of inpatient hospitalization, particularly within the last several months, is a very high predictor. Again, comorbid borderline personality disorder, we're having some patterns start to emerge. A subjective rating of very severe depression, a pessimistic and inflexible cognitive style in general, and then someone who has a significant level of impulsivity and aggression is also more at risk. With borderline personality disorder, within that diagnosis itself, what we find is that the more unstable someone is in their mood, the more dysregulated, the higher is their likelihood of suicide behavior. The more their identity is disturbed, meaning that they can't really tell you who they are. Often people with the most mood instability are also those individuals who have a great deal of identity disturbance because their continuity of experience is so disrupted it's difficult for them to have a continuous sense of identity. So those folks tend to have pretty high suicide behavior. And then of course if they engage in impulsive behaviors in general, you're going to see more suicide behavior included in that category. Criteria that is most predictive of suicide attempts, though, is actually that mood instability. So the higher they score on any of your subjective and objective tests, projectives and objective tests of mood disorder, the higher their likelihood of suicide attempt. Suicidality in borderline personality disorder is highest in individuals in their early 20s. They are more likely to complete suicide, however, after the age of 30. So, dialectical behavior therapy is a treatment of choice for borderline personality disorder, and it was developed for individuals not only with that diagnosis, but for anyone who has multiple difficult to treat diagnoses. And they are known to have a very high rate of suicide, so the treatment focuses a great deal on the suicide behaviors as a target of treatment. Suicide management protocols in DBT have been shown in 10 random controlled trials to be effective at reducing suicide behaviors. So not only suicide attempts, but also at reducing suicide thoughts. And we know that the greater the time someone spends thinking about suicide, the higher is their likelihood of engaging in behaviors associated with suicide. And so if we can reduce their behaviors, impulsive behaviors, but also thoughts associated with suicide, we can reduce overall risk of suicide, death by suicide. So this is kind of a general overview, a step-by-step guide for management of suicide behavior, and we're going to talk about a number of protocols in very brief fashion today. But in general, this is how you manage suicide behavior. You initially start with a good assessment of the person's long-term and short-term risk factors. And so that means that it's likely you're going to need to memorize factors associated with suicide for the general population and for a variety of diagnostic groups. Then follow the general guidelines for suicide behaviors when they present immediately in session, or if the person that you're working with has a high risk of suicide in general. Develop a treatment plan that incorporates management of both high risk and suicide behaviors, and then follow whatever protocol is indicated at the time when you're doing treatment with them. And we're going to talk about a crisis protocol, ongoing suicide behavior protocols for individuals who are more chronically suicidal, and a hospitalization protocol. When do you actually think about putting someone in the hospital? And we don't do that for people who practice dialectical behavior therapy. You know, we don't put people in the hospital very often, but there's certainly criteria that we're looking for when we do that. And then we always want to respond actively to patient suicide behaviors. So, for instance, thoughts and behaviors associated with suicide, we no longer refer to as gestures or attention-seeking kinds of behaviors. We're actually always going to consider those behaviors very seriously, even if they are recurrent and without serious suicide attempt that follows them over a long period of time. Okay, so to start off, we'll talk about suicide assessment. How do you do this? What factors do you consider when you are looking at someone who walks into your office, maybe isn't even talking about suicide? How do you assess their risk? And the long-term suicide risk factors really can be associated by looking at person variables, behavioral variables, and environmental variables. And so I'll talk about each of those a bit. If you consider the person variables, these are things that we can't change ourselves. These are things that are part of how we were raised, our biology, our genetic history, and the country we were born in. So there are risk factors we know that are associated with each of these things. Biochemical genetics, some of those factors include having a family history of depression, bipolar. Even self-harm behaviors are beginning to have some kind of genetic markers. We're finding those in some of the research. So there are certain biological predispositions and genetic predispositions for suicide behavior. Learning history are things like having a helplessness, hopelessness sort of learning history where the person learns that they cannot act on their own behalf in a way that's effective in changing circumstances. And so they may have been a child that was raised within a very abusive home, and they were not able to act on their own to protect themselves. So they develop a passive learning style. We also know that some of that seems to be temperamental or genetic, a passive learning style rather than active coping style. And so whether it's learned or whether it's genetic, that's one of the characteristics that we see in individuals with a higher risk of suicide behavior. Demographics, there are different kinds of risk that are presented with gender, race, age, and nationality. None of those are things that we can change. So most people are aware that more females commit or attempt suicide than males, but that males tend to have more serious, more lethal suicide attempts, and so more of them die by suicide than women. And every race, every age group is associated with a different risk of suicide. So simply by being born into a particular race, in a particular nationality in a country, being of a certain age is going to put your clients at risk. So you need to know those categories. They are easily available on the Center for Disease Control's website, on some of our suicide education websites nationally and statewide. Behavior variables are things, these are behaviors that the individual engages in. So cognitive variables, these are things that can be changed and that we often try to intervene on in therapy. So we're going to attack cognitive processes pretty directly when we're doing treatment with someone who is suicidal. Some of the content of the thoughts of people who are suicidal tend to be focused on hopelessness, helplessness, and worthlessness, that cognitive triad of depression. The processes of people who are more likely to be suicidal tend to be rigid, inflexible, they don't have very good problem-solving abilities, and these are all characteristics of thinking of people who have major depressive episodes quite frequently as well. So when someone comes in and they're talking in these ways, I just don't think things can get better, nothing I've ever tried helps, no medication has worked, those people are at pretty significant risk for suicide. The physiological, emotional, and mental disorders or behaviors, these are things like having a major depressive episode in that moment. So not only do they have a genetic predisposition for that, but they also seem to have a biologically based mood disorder. For whatever reason, they're experiencing mood difficulties at this point. If you're seeing physiological signs of depression, like the vegetative symptoms, not eating, eating too much, not sleeping, sleeping too much, and those kinds of things, that's a very big red flag. And you want to pursue, if there have been changes in routine or habit of that type recently, what those are traced to. And then overt actions, motor actions. Well, these are some of the obvious things, like keeping a stockpile of pills, having that door open to suicide. So they've got some sort of plan or thought that they're actively engaging in promoting. Let's say they get the materials they need for suicide, whether that be just the right kind of note cards to write goodbye notes on, or a gun, whether they plan out how they can get materials to kill themselves or do it. Those are the sorts of things that we're looking for. And then environmental variables are an interesting one. What we're looking at there really has to do with things that occur in the individual's life that they may or may not be able to do anything about. So one of those things is models, suicide models. We know that when there is a famous or a well-known, a close associate that commits suicide, individuals that either look up to or are close to that person are more likely also to commit suicide. And this is why when Kurt Cobain committed suicide, it was a very important event. And we've learned that when the media approaches suicide in a particular way, maybe sensationalizes it, when the person is eulogized and sort of honored and the suicide is at the center of that, people are more likely to follow suit, and there's a contagion effect around this. We have to be very careful when someone in a high school commits suicide. We know and have had, unfortunately, lots of experience with peers in that individuals' high school also commit suicide, or in the town commit suicide. So having models for suicide close by, family members that have committed suicide, that sort of thing, very important risk factor. Also, having available means. So states and countries where guns are less available result in a lower overall suicide rate, particularly here in the United States where guns are a frequent tool for suicide. A number of really interesting studies have been done relative to this factor. In one study in England, they had one of the leading causes of suicide there was asphyxiation by gas stove. And so when a noxious odor was put in the gas nationally, people were unable to commit suicide as easily in that way because they became overcome by the fumes and vomited and ended up coughing and having to seek relief before they actually died. Prior to that, it was odorless and a much easier route to suicide. Well, once they put this noxious odor in the gas, people stopped committing suicide in that way, or the rates radically dropped. Interestingly, people don't tend to gravitate to another source or method for suicide once their primary idea is no longer available to them. So in a number of situations that I've been in, when a client brings in their stash of medications and they don't have access to another stash, or when they hand over the weapons that they were going to use, or give the keys to someone and just stop driving if they were going to use their vehicle, they don't resort to another method. So assess carefully the methods that they've considered, know how flexible their plans are for suicide, and then be aware that if those particular avenues for suicide are cut off, the person is unlikely to then move to another. It's not impossible, but they're unlikely to do that. Other factors have to do with minority status, and this is an environmental factor too. And I'm not talking about ethnic background in this situation necessarily, but talking about that sense of isolation and alienation that people experience very often before moving into serious thoughts of suicide. So, interesting study relative to this was a community full of miners, like coal miners, were evaluated in this small town. And the study was initiated because they had an enormously high rate of suicide in this community. And so the researchers and people in general were interested in finding out what was going on in this group of people. They assumed that it had to do with the life of a miner. Most of the town was miners. And long hours, high danger, separation from families, that sort of thing were hypothesized to be the cause of this high rate of suicide. When they began to evaluate, though, the individuals who had committed suicide, they found that by and large it was the people who were not miners in this community. The miners themselves were a very close-knit group and supported each other and got through a lot of difficulty. The people who lived in the town who were outside of that group were often isolated, felt themselves to be alienated from this close-knit club or group that they could never break into, and those people were at much higher risk for suicide. So those are some of the environmental variables that you need to identify. It's not just about how good is their support system, because they may have a fairly good support system, but if they've had a history of models of suicide, if they have, so they sort of like they break the barrier and understand that this is possible. If they are alienated in their day-to-day life, even if they have relatives and friends that they see on occasion, if they have available means and they have considered using those means for suicide, these are really high red flags, whether they are suicidal in this moment or not. Certainly if they are feeling depressed or suicidal, you're going to be more concerned in that situation. And then, of course, negative life events was one of the factors I didn't talk about, and that includes divorce. Interpersonal events are very high on the list for negative events. For teenagers, the single highest association with suicide attempt for teenagers was not break up with a boyfriend or girlfriend, not low grades, not being kicked out of school, but it was actually having had a conflict with a parent or a primary caregiver. So really shakes up their sort of central sense of security and is associated with suicide behavior. Also for adults would be the first 24 hours of incarceration. So taking a look at those sorts of events in the person's life is really critical. So once you have a sense of, and you can know this before a person walks in the door, what the long-term risk factors are, what kind of person is most likely to commit suicide or to engage in suicide behaviors, then you've got to take a look at the individual themselves and identify what's going on for them at this moment that makes them a more likely candidate for suicide or not. And in terms of imminent risk, we're looking for these 4 factors. We want to know if they have suicidal thoughts. When they think about the most difficult events in their lives, do they ever consider the possibility of ending their own lives as a way of escaping that pain? And if they do, have they ever said it out loud to anybody? So this is suicide threats. Ideation, understand, can range from light thoughts that occur to someone momentarily and then provide a sense of relief because they think, well, I could get out of this if I wanted to images that are really vivid, almost daydreams with a fantasy of dying and having complete relief after that moment. Most often, the idea that a person holds on to when they're considering suicide is that it's going to be this incredible relief from pain and that they'll feel nothing afterwards, or they'll feel a sort of pleasantness like a drowsy, dreamlike state. It's important, I think, to let people know that we're not really certain exactly what happens to you after you die, and it could be worse. We just don't know. So I think dispelling those fantasies that they have that it's going to be better and recognizing that we don't have any clear idea or certainty about that is pretty important. Also, when they have suicidal ideation, they often think about these methods of death as being peaceful and quiet and calm. And that is often not the case. I think it's important for teams, clinical teams, to research and understand that death by asphyxiation is a very painful, uncomfortable death. There's no just going to sleep when you die of carbon monoxide poisoning most of the time. When people commit suicide in their garages in this way, there's often nausea, vomiting, seizures, people's bodies are bruised. So it's a very painful way to die. We think that there is awareness typically when someone dies by hanging. And so being aware of the discomforts associated with each method and being able to inform the clients about this is pretty important. You're addressing then that path to relief through suicide ideation, which often is what allows the person to act on it. Suicide threats often come as a way of retaliating against people who seem to be uncaring or who increase pain in life. And so assessing, have you ever said to someone that you're going to kill yourself? Or do you think with some kind of relief about dying and no longer having to cope with some of the things that people are presenting you with? So understanding their sense of retaliation or anger associated with suicide is important, because anger can be a fuel that activates people even more sometimes than hopelessness. Do they have a plan? Have they prepared this plan? And again, preparation can be something like just making sure they're carrying notebook paper so they can write a note. We want to be very careful in assessing what have they thought about, what kind of methods. And so they may tell you about one method of suicide that they've considered. Once they're finished talking about that, and you know if they have the means, and you know if they would do this in proximity to other people where discovery is possible or not, then you want to know, have you thought about any other ways of committing suicide? Has it ever occurred to you? Have you ever had another plan? And then have they done any intentional self-injury, whether there was suicide intent associated with that behavior or not? So cutting, burning, shutting their hands indoors, whatever the behavior might be. Have they engaged in those types of behaviors, especially if suicide intent was expressed at the time, but even if it wasn't, because we know self-harm behavior increases risk of suicide enormously. So for instance, in a borderline personality disordered population, their typical rate of suicide completion is 10%, but if they've also had a history of self-harm behavior, that rate goes up to about 30%. So it's incredibly important to assess that piece of it. So there are some, I talked about the direct indices of suicide behavior, but there are some indirect indices also. And of course, if the person that you're working with is in a suicide or self-injury risk group, by virtue of their age, by virtue of their nationality, their sex, regardless, if they are in a high-risk group, then you have to be cautious. Have they had one of those negative life events that we talked about recently, relationship changes in particular, but also in our current environment, we've got to look at the economic changes that are affecting people, job loss, those kinds of things. Malignant alienation from therapy is kind of a dramatic way to talk about having had a fight with your therapist and feeling like you can't go back. Medication non-compliance, people going off of their mood stabilizers and antidepressants and anxiety medications, very, very risky behavior. Acute hopelessness, anger, or both. Extreme psychological perturbation. It just means that they are really emotionally dysregulated. Recent medical care. Most people who commit suicide have seen a doctor within the previous week. Not necessarily for a mood-related issue, but for a physical issue. So we're having a lot of luck putting mental health care right in those medical clinics, doing direct assessments of mood, and then getting them hooked up with somebody who might be able to help. And then, oddly enough, recent clinical improvement can also be a risk factor. We think because individuals who have had difficulties emotionally then will sometimes begin to feel better, which fuels the energy and the motivation to harm themselves. So I'm not able to advance them because I've lost power. I can't tell when they're advanced or not. It's gone dead. We're having some technical difficulties, so I'm going to talk about the next slide, which is about really imminent risk of suicide. So if you are concerned about suicide occurring during the next days or hours of an individual's life, then you want to be looking for the things that are on this slide. And those methods are easily obtained, very available. So be watching, knowing ahead of time what their thoughts about suicide are, what their previous attempts have involved, and that sort of thing. Know whether or not those means are available. Now, in our highly risk-averse culture, we very often, especially in our state, put people on under guardianship. We put them in living environments where they're not able to access means, or we think that they're not able to access means for long periods of time. Ideally, we would keep these folks in the community and recognize fluctuations in their risk. And sometimes it's okay if they've thought about harming themselves, thank you, Tom, with a knife. It's okay for them to have knives to be able to cook, to be able to cut their meat at dinner time, but not during times that they're thinking about suicide. And so in an outpatient clinic, it's really common for clinicians who deal frequently with suicide to say to someone, is it a good idea for me to take the extra medication, or for us to be doling those out weekly to you instead of having you keep them at home during this time? Should you bring in your knives and simply prepare foods that don't require them for a while? So you want to make sure that you are helping individuals maintain safety in their environment by making those changes in the environment that are going to be helpful. One thing that a lot of communities are doing, and there's been a very public change in this at the Golden Gate Bridge, is to take iconic suicide structures and put safety netting around them, or in some way otherwise make those structures more difficult to commit suicide off of. And again, very often people don't pick another suicide method. They just think, well, I can't do that either now. And so they get a little discouraged and they move on to thinking about, how am I going to go on living then? Are they someone who relies on alcohol or some kind of drug in order to cope, and are they currently overusing? Do they have alcohol or drugs available to them? And I have on occasion taken somebody's favorite bottle of brandy and just stored it behind my filing cabinet for a period of time, returning it to them potentially when they were feeling better. Isolation. Are they cutting themselves off from what would otherwise be means for support? Are they not wanting to get out of bed? Are they closing themselves up in their houses and refusing to come to therapy or to group? The first week after inpatient treatment, or the first week of inpatient treatment and then the first week after discharge, tend to be high-risk times for individuals who are suicidal. And then if they're being deceptive about their methods, if they tell you, I wouldn't necessarily want to be caught. If I were going to do it, I would make sure nobody found me. If they've made attempts in the past that made it difficult for other people to intervene, then you've got to be very careful as well, because that shows planning and intent that goes beyond just even an impulsive behavior. Okay. So how do you want to treat this? Again, this is not a complete review of guidelines for treating suicide behaviors, but just in general, you want to be flexible. There's no one-size-fits-all kind of method for approaching suicide behavior. You want to be more active when suicide risk is high, so jump in, be directive, tell them not to do it. It's a bad idea. Get their means away from them, separate them from the things that they might actually cause themselves harm with, and just in general, being directive and active during those time periods. Don't be afraid to do that. This third point says base non-conservative responses on a failure of conservative responses. So conservative responses being what you would typically do. So if you would normally hospitalize someone, if you would normally get a safety plan or a contract, and those things are not working, then move to doing something that's a little bit more radical. Now, typically in dialectical behavior therapy, if they have a good outpatient program, we probably are not going to hospitalize them very often. But if all of the things we typically do are not working, they're at high risk, then that's when we would do something like hospitalize, and that would be our non-conservative response. Be honest about your reasons for hospitalizing when you do it. Very often the clinicians are just exhausted. You've done coaching calls, you've done your crisis line, they've just burned down the phone line practically. You are tired, your team is tired, people are starting to get resentful. It's okay to put somebody in the hospital when they're at high risk and presenting with that kind of difficulty. Give yourselves a break. If you're afraid of liability, you're afraid they're going to commit suicide and that you'll lose your license, that you will be at risk in your agency if you don't do something more conservative, tell them that that's why you're putting them in the hospital. Let them become responsible for helping you feel safe about them being out of the hospital. That's okay. But to say that there's nothing you can do outpatient, to say that there are no interventions that would be helpful for them is not true. There are things that we can do outpatient. We don't always have the reserves to do that, though, and that's okay. Talk about suicide openly and matter-of-factly. Sometimes we get so afraid of this topic that we don't want to approach it. We say, have you thought about doing something to hurt yourself? And we can't even bring ourselves to say the word suicide. It can be an enormous relief to a client when you say to them, are you thinking about killing yourself? Do you have anything that you could kill yourself with, that you've thought about hurting yourself with? And then avoid pejorative explanations. You're doing this for attention. You're doing this because you're selfish. Those kinds of interpretations and that sort of talk is not therapeutic for people. That usually is a result of our own frustrations and struggles in the face of this behavior and is not helpful to the people that we serve. It's often very validating for people when you say, you're in such a tough spot, it's hard to think of anything to do except suicide to get out of this. To say, this is how you're trying to solve the problem, and that makes sense on some level. And I think that there are other solutions, which is number 8. Maintain the stance, no matter how persistent this behavior is, that suicide is never the solution. We have an ethical obligation to do that, regardless of how discouraged we might be or how convinced we are that this client is not going to get better. I have worked with some of the most chronically, abysmally suicidal people I have ever met, been half convinced that they weren't going to get better, and then been surprised years down the road in the face of the most persistent depression. So there really is no way for us to predict whether someone is going to get better or not. And ultimately, my own experience is that they always have periods of relief, and substantial periods of relief, if we just hang in there long enough with them and try enough things. Involve significant other people in their lives, including other therapists for yourself and for the client. So make sure that you have safety information for them. That way you may or may not have to rely on hospitalization. Emergency personnel are not the only people that you can get a release of information to. I mean, obviously you don't need a release for emergency personnel, but for family members, friends, people that the individual would respond to in the moment of crisis, get that information and rely on those people. Get them to include those people in their crisis plan. That can be really helpful in avoiding hospitalization and the suicide behavior. And then schedule sessions frequently enough with additional sessions as needed. And the caveat there is make sure that if you're adding sessions, you are not reinforcing suicidal behavior. So if this is the only way your client can get contact in your system, that's a problem. You want to make sure that they have the services that they need on a regular basis. Oftentimes when people don't have coaching calls outside of regular therapy, they will rely on crisis lines and will generate crises so that they can justify calling. So you want to make it easy to get a hold of you when they're doing well, and then if you need to add a session, to be careful that it's not reinforcement of suicide behavior. Stay aware of the multitude of variables impinging upon clients. So it's amazing to me, working with individual therapists and case managers, how often the case manager learns something that's going on in the client's life that is really enormous, like a relative died or their child got kicked out of school, and therapists never hear this information. So having a way of kind of assessing what's been going on that may or may not impact the client's mood and suicidality is critical. Don't assume that you can save every client. The likelihood is that for most of us who deal with a high number of suicidal individuals, there will be a client who in the course of our career suicides. And you need to maintain consultation with trusted colleagues, with experts, in the face of a high caseload of suicidal individuals so that you can make sure You're not assuming that you can save everybody and over-functioning for the clients in a way that's not helpful to their treatment, or under-functioning out of a sense of helplessness and hopelessness. Then people who drop out of therapy, this is really interesting. A study was done in which a therapist, a researcher actually, dropped note cards in the mail to clients who were suicidal and who had dropped out of therapy and just said, listen, I'm thinking about you. You've been on my mind. Love to see you sometime. Just know that the door's always open. And they had a 50% reduction in individuals who received those cards over people who did not. So occasional non-demanding contact is really important. And I think that in this age of electronic communication devices, it's easy to send a text if you are in the habit of texting with your clients, or even leave a voicemail. It doesn't have to go through the mail, but those are some ways that you can reduce suicide even with people you're not treating at the moment. So our treatment as usual approach to conceptualizing suicidal clients is that suicidal behavior is just a symptom of an underlying problem, and that if we treat the underlying problem, be it depression or bipolar disorder, relationship problems, a personality disorder, then we have had this long-standing belief that suicide behavior will inevitably go down. The research, however, the empirical research shows that that is not the case, that the only way that we can really effectively address suicide behavior is to treat the suicide behavior directly. So consider that the target of your behavior. So the idea would be that instead of talking about the depression, instead of talking about the life events that are so difficult, you would directly and specifically talk about the suicide behavior itself every week in therapy and problem solve when and how that behavior arose and occurred, and do solutions that are addressing how to reduce that behavior. This is the crisis protocol for suicide behavior. You want to, again, assess the long-term and imminent risk of self-injurious behaviors. When you're talking with someone who's suicidal, focus on what's going on right now. They are going to be inclined to look back on their lives in a long fashion, philosophically perhaps, and talk about all of the things that have gone wrong in their lives, all of the things they expect to go wrong in the future. But you have to try to hold them to the present moment. Do not assume that other crisis moments are actually connected to or related to this crisis moment. Just stay with this one. That's all you have to solve. And sometimes if you tell them all we have to do is get you through this moment or this time, and then things will be better, it's a relief to them. Problem solve the current problem. What's going on right now? Reduce high-risk environmental factors. We've already talked about that, so get the implements of self-harm or suicide out of there. Reduce high-risk behavioral factors. So let's say they are driving around, drinking, going out and socializing with people that they get into trouble with usually, or people who reject them. You want to problem solve some of those situations and try to get them to lay off of that stuff for a while. Commit to a plan of action. So when I'm working with somebody, for instance, who is, let's say, engaging in high-risk behavior like driving around late at night when they feel the worst, I'm going to talk with them about giving me a coaching call when they start to feel depression or hopelessness at a certain level, which we put on a rating scale of some sort. So they'll know when my stomach sinks, when my heart is racing, when I feel like I can't go on, I'm going to give you a call. And then we're going to have a plan for what they're going to do at that point that is not going to be driving around late at night with a beer. And then I'm going to troubleshoot that plan. What's going to get in the way of you calling me? What is going to prevent you from following through on this plan, this safety plan that we've developed? Typically, when you've got a good plan in place, they're going to feel better. They're going to feel more hopeful. And you have to bring up the option, the possibility that this is going to recur, that they're going to feel bad again, maybe in an hour, we just don't know. And then what are you going to do? And finally, at the end of this contact that you have with them, whether it's in session or on a phone call, reassess how they're feeling on the level of suicidality. Have a rating scale that you're both familiar with, you both understand the meaning of, and then encourage them to use that rating scale when you talk to them on the phone. How high are your urges to suicide right now? So when you're involved with somebody who has a lot of suicide behaviors, as is typical of the population that I treat, one of the things that you're going to do is have a really good assessment in the chart and in your head for that patient. Never let that go undone. And then when they call you, if they have already engaged in a suicide or self-harm behavior, you want to ensure that you're not reinforcing it with your relationship. You want to have a powerful and positive relationship with these clients. And so in the moment that they call, having already engaged in self-harm, you want to make that phone call just as short as you can make it. You want to be pretty neutral in your affect and your response to the person in that moment. You assess the medical danger. Do they need medical care? And if so, you make sure that you get them that medical care, that they go to the hospital, that you get a promise from them, or have them contact somebody while you're listening on another phone. And then you get off the phone as quickly as you can. They are to get all kinds of kudos and encouragement and support when they are not engaging in suicide behavior, and very little when they are. We do just what is needed when they are and get off the phone. If they don't like being on the phone, then you stay on the phone. So you want to look at the contingencies. What is the meaning of contact with me? What we don't want to do is help them find absolution by talking to us after suicide behavior. They feel shame and have the almost compulsive desire to apologize, and we don't want to engage in that kind of behavior with them. After someone has engaged in suicide behavior, let's say they've called you, they've said, I cut myself, and you get off the phone as quickly as possible. The next session, when you meet with them, you're going to be finding out how many times did it happen, how severe was it, and you're going to assess that behavior very thoroughly. So we don't shy away from talking about it in session, and we do it in such a way that we get a very thorough evaluation of that behavior. We do what is called in DBT a comprehensive chain analysis of the behavior. So we may look at a 30-minute segment of time and get lots and lots of detailed information about what was going on right before the behavior occurred, what made them vulnerable to having that behavior occur that day, what were the outcomes of that. And we want to identify, was that behavior driven by something that happened before, or was it reinforced by something that happens afterwards? So let's say they feel shame and hopelessness after they have a fight with their mother, in the case particularly of an adolescent with some depression. And that's when they engage in the self-harm behavior. But then say that the adolescent's mother then becomes very nurturing and concerned when she sees that there's blood on the sheets or bloody tissues in the garbage can, and is supportive of that teenager right after the self-harm. So you might say that the shame kind of compelled the behavior, and then the nurturing and the contact with mom maintained the behavior, and you've got to intervene at both sources. So it's a very behavioral model for intervening with suicide behavior. Relate the current episode to overall patterns in the client's life. Validate that this was extraordinarily painful and hard to deal with under any circumstances, and then focus on the negative outcomes of suicide behaviors. So you don't feel necessarily less shame after you self-harm. It feels more inevitable after that. People don't trust you. You have more restrictions in your behavior. You can't stay in the housing that you have sometimes, if it, in the case of a shelter. You want to reinforce their non-suicidal responses. What are they doing to cope when they're not engaging in suicide behavior? How did they get through it other times? What have they done? And how can you make those responses even stronger, more common? And how can you add to their repertoire? And then you want to obtain a commitment, just like in the case of a crisis call. You want to get a commitment to what they're going to do differently. Hospitalization is really considered when these factors are present. Someone is psychotic and they are engaging in suicide threats. Very often these folks are kind of out of control. The second point is suicide risk outweighs the risk of inappropriate hospitalization. So if you're so worried, you don't know the client, say, and you're not sure what level of risk they present because you don't know their patterns around threats of suicide, then putting them in the hospital is the safest bet, and you should do that. If you know the client very well, you know that they have skills that they can rely on, putting them in the hospital may actually reinforce suicide behavior, and so we have to be careful of that. Operant suicide threats are escalating plus hospitalization is aversive. So operant means that they're getting something out of it. There's a secondary gain to being hospitalized or to being suicidal, to saying that they're suicidal, but they hate being hospitalized. So the teenager gets a lot of nurturing and support from the people around her. Her whole social group rushes to her side if she self-harms when she's cutting. That means it's operant. That means that something is holding that behavior in place, but she hates going to the hospital. That's exactly the time I would put her in the hospital, and we'd work on that operant behavior. If you are not connected to your client in the close and critical way that you have to be when you're working with suicidal people, there's been some kind of a rift, then you probably want to consider hospitalization more seriously. And when somebody's on a lot of psychotropic medications and you're worried about them suiciding, then it's important to put them in a place where somebody can manage those medications. Or, totally appropriate, when the therapist needs a vacation. Consider hospitalization if you're going to be doing a lot of exposure treatment during treatment of post-traumatic stress disorder. They're going to be reliving memories and they have suicide behavior in their history. If they are non-responsive to therapy at all, they're not getting better and they have a disabling depression or anxiety. They have overwhelming crisis, terrible things going on in their lives. They are not safe at home. They're not safe at work. They're not safe on the streets. Put them in the hospital. And then if there is psychosis, little social support, and suicidality, then of course you want to consider hospitalization. You don't necessarily want to put them in the hospital, but you at least want to think about it. For further information, I know we've run at about the hour mark, so I'm not sure if there's time for questions or not. But for further, apparently we can do questions. For further information, you can go to behavioraltech.org, which is information about dialectical behavior therapy, or you can email me. In addition, we have a website in the state of Missouri, and people outside the state of Missouri are welcome to visit this website, which is www.dbtmo.org. And I'll take a question or two if we have them.
Yeah, we do have a couple of questions that have come in, Rhonda. One goes back to your exposition and talking about some of the background information. And I should let everybody know that we've got Scott Perkins in the room, too, who's our statewide suicide prevention expert. And the reason that I bring his name up for this question is, do either of you know if there's any work to collect more current data than the stuff that you cited?
Oh, absolutely. And the CDC probably, if you go to their website and look up suicide, they, I'm sure, have much more recent information than this. And there are ongoing studies all the time in personality disorders and for borderline personality disorder, antisocial, those kinds of things, looking at associated risk factors. So, Scott, did you have anything to add to that?
Okay, he concurs. Another question, these interventions are for people who are seeking treatment and want help. What do you do for the suicidal patient who does not want help? Yeah,
I mean, that's really tough. I mean, for anyone who is anhedonic, just experiences no pleasure, feels completely hopeless. It's extraordinarily difficult to intervene, and this is one of those situations where I think the depression is overwhelming or crippling, treatment is not working, and that's when you put them in the hospital and you see if there's a medical intervention that may be of benefit, whether that be ECT or medication, a new medication. I think it's important to consider all of the options when you have a chronic suicidality, and psychotherapy is not seeming to be of benefit.
And within the framework of DBT, you use validation a lot, but someone asks if within that framework, is there ever any room for considering suicide justifiable?
Well, not if you are licensed as a mental health professional. We have certain ethical guidelines that require us to be on the side of life. If you are a treatment provider, then you are making a commitment to do no harm, which means keeping people alive in our culture at this time. So whatever your personal views are, and I respect a wide diversity of personal opinions on this, our professional perspective and our work in treatment is always to side with life.
All right, those are the questions that we had come in today. Folks, I want to encourage you to take a look at the website, because we do have another program coming up on Monday afternoon that is kind of an overlapping topic. This is called Preventing Teen Suicide, What to Look For, What to Do. It's later in the afternoon than our usual programs. We're starting at 3:30 Central Time, and that's largely because we hope to capture some of our folks who might be school teachers, counselors, social workers involved in schools, maybe even parents, especially targeted towards middle school populations. So if you know anybody, please refer the website, mimhtraining.com. The link is right there at the top of the page to Monday afternoon's program. Also, since we're sitting in Jefferson City, Missouri, in the home of the Missouri Department of Mental Health, it wouldn't be fair of me not to plug their live program, their conference that comes up at the end of May, 1st of June, May 31st and June 1st. It's their annual Spring Training Institute. And that's a large-scale 2-day event. We've got 9 learning tracks. We'll probably have about 60 different sessions. There's a special website for that. You can link to it off of mimhtraining.com, or you can go to mimhtraining.com/STI, and that'll have a lot of the information that we currently have available on that program. The early bird registration rate is currently available. So, folks, I wanted to thank you for your time joining us today. We had a lot of folks out there watching. We appreciate your time. And, Rhonda, we appreciate your time and your expertise as well. Thank you.
Thank you.